cover at your request in the hour. So I've been a PT for now 38 years, doing pelvic health for 28. A lot of this knowledge base that I have comes from the fact that I teach for the Academy of Pelvic Health of the American Physical Therapy Association. These 3 courses, which are each 3 days in duration. So trying to pull at least 3 days into an hour is a challenging feat. And I wanted to have the opportunity for you to do some activity as well. So I am going to jump right in. Hi. So the request was about fitness and exercise in pregnancy and the postnatal condition, addressing cesarean and vaginal. So we'll touch on that. Then we'll go a bit into ergonomic education and posture. And I am making the assumption that you have some of this data already, like how to look at posture and teach body mechanics in a non-pregnant population. So we'll touch on just some of the variations to consider. So in general, when a person becomes pregnant, they do have increased aerobic capacity. They have a greater blood volume. They use more oxygen, but they have increased methods of delivering that oxygen to the cells, so they can still exercise during pregnancy. Also, oftentimes there's a concern for what about hyperthermia or getting overheated with exercise. Being pregnant allows thermal adaptations. Again, that increase in blood volume and the increase in the surface area allows the person to dissipate heat. So now we're talking about, well, what does exercise do to pregnancy? And the overwhelming data is that exercise is good for pregnant people. Particularly, it improves the cardiac autonomic control. It increases the relative, submaximal, and absolute VO2 max. It can reduce the resting heart rate and reduce systolic and diastolic blood pressure. It also helps pregnant people manage their sugar. So a common condition in the United States is type 2 diabetes. Gestational diabetes occurs in about, I don't know why that went forward, about 10% of pregnancies. And it's related to type 2 diabetes. So helping a pregnant person manage their sugar is good for their health and the health of the fetus by decreasing that risk of gestational diabetes. Some additional benefits are physical and emotional health. It can help reduce excessive gestational weight gain. And so for someone of a normal BMI, that's keeping them within that 35, under 35 and about 25 to 35 pounds. It can reduce depression associated with pregnancy, reduce varicosities, and reduce some of the discomforts of pregnancy. People can become more fit when they exercise during pregnancy, and being stronger and more fit helps people accomplish their ADLs and have good posture and body mechanics. It improves, sorry, this is super sensitive. It improves their sleep, their breath awareness, and self-image. So it is good for pregnant people to exercise in a cardiovascular fitness way. When there are some studies, and I also sent Connie a kind of a resource list, like where a lot of this data came from, and categorized it there. So there were about 6 studies by Davenport is the primary author. But when they looked at a systematic review of pregnant people who exercised compared to people that didn't exercise, or control groups that didn't exercise, it reduced the odds of developing gestational diabetes by 38%. When looking at preeclampsia and also gestational hypertension, so blood pressure higher than 140/90. Exercise reduced the odds of people developing preeclampsia compared to groups of people who did not exercise. And so in the exercise groups, there was a reduction of 41%. So we're just kind of touching on the benefits here. And, when you look at population studies, and the overwhelming evidence is that this is good for people. It helps not only their general health, but it reduces disease occurrence. It could be tempting to just say, like, okay, 100% of pregnant people should exercise. But there are some contraindications to exercise. And you may have seen that I was involved in the obstetric education from 2012 until now. And those lists of contraindications have changed. And this was about 4 years ago. There was an article that came out in 2020 that really looked at, are we limiting people from exercising because we're overly concerned about their safety, and are we actually doing damage? So if any of you had an evidence base for what is safe in exercise, a resource that you used in the past, 2015 or 2012, this is more current information. So the absolute conditions when people should not exercise are things defined as severe respiratory disease. So something like COPD or emphysema in a smoker. If they have severe acquired or a congenital heart disease, and in their unpregnant state have exercise intolerance. If they have an uncontrolled or severe cardiac arrhythmia, if they have placental abruption, which is when the placenta is pulling away from the uterine wall, and that is a risk to the fetus, that alteration in blood flow could lead to fetal demise. That is happening completely on its own. Vasa previa is when there are veins of the placenta are over the cervix, and the cervix is the exit of the uterus. If they have uncontrolled type 1 diabetes, the concern for that is that with uncontrolled type 1 diabetes, people are likely to go into a hypoglycemic event, and exercise can contribute to hypoglycemia. So it is discouraged when people have poorly managed or uncontrolled type 1 diabetes. If there's an intrauterine growth restriction, so for some reason the uterus isn't able to expand, or the space for the fetus to grow is limited, that could be due to an excess of amniotic fluid, and sometimes cesarean scars or the age of the mother. If they are in active preterm labor, preterm is defined as a person going into labor before 37 weeks gestation, and an active labor is when the whole uterus is contracting, so not just one quadrant of the uterus, and the contractions are lasting from 30 seconds to a minute and occurring at least like 3 times in an hour in that preterm state. And if they have severe preeclampsia, so they have that high blood pressure and kidney issues that have developed as the pregnancy has proceeded, and cervical insufficiency, and that is when there's a weakness in the cervix opening that could contribute again to that preterm labor or loss of amniotic fluid. So those are when you would not want people to exercise. Some relative contraindications are mild respiratory disorders. So people with asthma can exercise. If they have mild congenital or acquired heart disease. If the type 1 diabetes is well controlled, you still want to be mindful for hypoglycemic events. If they have mild preeclampsia, so they're not always over that 140/90. In people who have preterm premature rupture of membranes, so that is when the amniotic sac has a leak in it before 37 weeks gestation. It is still, they're going to be monitored for their weight and the amount of amniotic fluid loss, but we don't have to absolutely say they cannot exercise. Placenta previa, which is similar to that vas previa, but that's when the placenta is within 2 centimeters of the cervical opening. It is okay for them to exercise if they have that placenta previa before 28 weeks gestation, but they cannot after, or it's with caution. Untreated thyroid disease, if they have an eating disorder, if they have nutrient deficiencies or chronic undernutrition, and really thinking about iron and calcium for cardiac and vascular health and bone health, and if they are someone who smokes greater than 20 cigarettes per day. So moving on to warning signs to stop exercise. So these will be people that either had no contraindications to exercise, or they were in that relative contraindications to exercise group. Some of the warning signs to stop exercise are vaginal bleeding. That could indicate something going wrong with the placenta previa or the placental abruption. Abdominal pain. That could indicate uterine contractions. If they're having regular painful contractions, amniotic fluid leakage that they're not already aware of, any dyspnea or difficulty breathing prior to exertion, any headaches, any chest pain, muscle weakness, or calf pain and swelling. So now we're going to move on to cardiovascular exercise and types of cardiovascular exercise. So it is safe to start the following activities when someone learns that they are pregnant, or if these are activities they already do, it's safe for them to continue. So things like walking, swimming, exercising on a stationary bike, low impact aerobic, so not a lot of jumping and landing, modified yoga, Pilates, if it's modified, and we'll talk about some of the modifications to make, running or jogging, racket sports, or strength training. Things to use caution with: contact sports, so maybe things like basketball and soccer, where players might run into each other a little bit more. Activities that have a high risk of falls, things like skiing, cycling, or roller derby. Scuba diving, and many people would put that into an absolute caution because of how the nitrogen is managed in the fetal circulation. Skydiving, hot yoga or hot Pilates, so exercising in environments that are in that over like 105 degrees Fahrenheit. Ways to avoid overheating. So obviously avoiding exercising in high heat or humidity. So we talked a little bit how hot it is here in Portland, and that is atypical. I would imagine that it is hotter and more humid where you are. It is safe for a pregnant person to exercise, and there's very low risk of them becoming hyperthermic, which is 102 degrees Fahrenheit as a core temperature. People can exercise for 45 minutes at 32 degrees Celsius, which is about 90 degrees Fahrenheit. and a relative humidity of 45%, and they are not at risk for developing hyperthermia. And moderate vigorous exercise does not induce hyperthermia on its own. It really is, the environment is the main contributor to that. Being mindful of hyperthermia, we want to know what the signs of heat stroke are. We want to educate the pregnant person and their partner or people they might exercise with. So it could be an altered mental state, nausea and or vomiting, if their skin is flushed and more reddened, if they're having rapid breathing, so something over about 20 breaths per minute, if they have a racing heart rate or a headache. So tachycardia, if it's getting in the like 120 or 100 beats per minute and they are not exercising. Ways to stay cool and reduce that risk of hyperthermia is exercising in cooler environment. Drinking cool beverages cools the person more than just drinking water alone, and cooling their body temperature prior to exercise. So maybe taking a cold shower or a cold bath. And if they do become hyperthermic or they're close to that, having some of those signs and symptoms of heat stroke, these studies weren't done on pregnant people, but the fastest way to lower someone's core body temperature is with cold water immersion. When we're talking about fluid intake and calories, so a way that people can be mindful of their fluid intake or calories is to weigh themselves before and after their workout. So 1 kilogram of mass equals 1 liter of water. So it's a good way for the person to know how much fluid they should replace if they weigh themselves before the exercise and after. And additionally, a pregnant person has increased energy requirements. So in the first trimester, there aren't really increased calorie requirements. In the second trimester, it's about 150 kilocalories per day. And in the third trimester, it's about 450 kilocalories per day. So there's variation, and the caloric intake should be individualized. This should be based on the pregnant person's weight gain, which is likely being monitored by their obstetrician. Signs of overtraining. And really, if someone is overtraining, the solution is to reduce the training intensity, frequency, or duration of the exercise and increase the rest and recovery. So some of the signs of overtraining could be bradycardia or tachycardia. It could be hypertension, which again, we're defining as 140/90. The person could be fatigued. They may have difficulty sleeping or restlessness. They may have mood changes such as depression, irritability, agitation, or loss of motivation. Some of the parameters, if someone is starting a cardiovascular program, would be to encourage warm-ups with that program. So warm-ups and cool down. So there's a gradual change in the demands on the heart and the pooling of the blood in the extremities. So a warm up and cool down of about 5 to 10 minutes duration. While they're exercising, they can exercise at a moderate intensity, which is a 13 to 14 on the Borg scale. The talk test is a way to monitor the intensity of the exercise. So if the person can talk, but they cannot sing, then they tend to be working at a moderate intensity. And people can also look at 60 to 80% of their age predicted maximal heart rate using that core equation. But new exercisers should start more at this 60% of their age predicted maximal heart rate. The duration could be about 20 to 30 minutes per session. It could be more if the person's well trained, but it's advised that they limit that to only 45 minutes of high intensity sessions. And that's just to reduce the risk of hypoglycemia. And the frequency is at least 3 days per week. And if the person is new to exercise, then starting with 3 days a week. And that doesn't mean 3 consecutive days. What we're looking at is at least 1 day off between the exercise sessions. High intensity interval training is safe for pregnant people. And what I like about high intensity interval training is it can assist in removing that barrier of time. Getting pregnant people to exercise if they have a family at home already or if they're working. People oftentimes don't have time for a 20, 30, 45-minute session. With high intensity interval training, people can do short bursts of activity so they can get the benefit of a 45 to hour-long session of continuous moderate activity in a 20-minute session, for an example, doing 1 minute at high intensity at about that 70 to 90%, and then another minute at the 40 to 70% is one. So a minute on, a minute off, going through that cycle 10 times is a way to get the same benefit of a slow, steady state. And there were multiple studies, which you have the references for. These were on people who were pregnant with only one fetus, and it was in their late second trimester and early third trimester. So they were well into their pregnancy, and it included people who exercised prior to their pregnancy and people who were new exercisers in pregnancy. So now we're moving on to postpartum. And I think my slides are advancing themselves, so I'm apologizing that I have to move backward so often. So even if someone did not exercise during their pregnancy or they did not exercise before their pregnancy, there is still benefit to postpartum exercise. They can get improved cardiovascular fitness, decreased stress urinary incontinence if pelvic floor exercises are part of it, decreased depression, and there's insufficient evidence to say if exercise alone can help with postpartum weight loss, anxiety, or the person's mood and affect. It is safe to resume exercise. So to the question of vaginal birth or cesarean birth, if somebody had an uncomplicated pregnancy and an uncomplicated vaginal birth, so they didn't have a grade 3 or 4 tear, the duration, they didn't have an injury to the coccyx, they didn't have an injury to the pubic symphysis. In reality, they can exercise as soon as they feel ready, listening to their body, listening to their aches and pains, some of those same things that we talked about in pregnancy about the rest and recovery will matter. If it was a complicated birth or pregnancy, they can discuss with their obstetric provider about returning to exercise. But generally, people will be okay to exercise at 6 weeks postpartum. And this could be with somebody who's had a cesarean birth or a vaginal birth. But we can't make a blanket statement about it will always be okay after vaginal birth or 6 weeks is enough for cesarean. No, people who have cesarean should wait for 12 weeks. Similar to how we talked about individualizing the pregnancy exercise program, we want to individualize the postpartum, ask questions about pain, ask questions about incisional pain in people who've had a cesarean, ask questions about vaginal bleeding in people who've had a cesarean or a vaginal birth. What the situation we really want to avoid is having people at a zero exercise level and then a rapid change. We always want to be working gradually and responding to their symptoms of pain, their cardiac and respiratory function. Pelvic floor and transverse abdominis exercises can start immediately. And as I stated earlier, everything we're looking for is a gradual return. And I chose this picture because she's doing a modified plank. Some considerations about how well will someone return to postpartum exercise is what was their fitness level prior to pregnancy or during pregnancy? What was the duration and intensity of the labor and birth? So in general, birth from the onset of the first stage to the birth of the child could be about 24-hour duration. That would be acceptable. It definitely can go outside that window. There are things like an epidural. There are things like the positioning of the fetus that could change that. The use of forceps for the birth of the fetus and the need for the episiotomy. How well have they recovered from those complications? If they have had after a vaginal birth, people will lose about half a liter of blood. After a cesarean birth, it is about a liter. So if they're experiencing anemia, that is going to limit their ability to have a safe return to exercise. What is their return to work timeline? Do they have time to exercise? Will they be able to moderate it as well once they return to work? And are they having any urinary incontinence and low back pain? Some barriers to exercise are the time constraints, the motivation, unrealistic expectations. I don't know what it's like there, but there's this big push to get back to your pre-pregnancy body. Have they recovered from the pregnancy complications, lack of energy or fatigue, which could be lack of sleep. It could be that anemia. It could be overtraining, childcare needs. Oftentimes, the mother is the primary provider of childcare, other family responsibilities, lack of support. So if they don't have family members around, and if they have to pay for a gym membership, or the weather is either too hot or too rainy or too cold to exercise. When we're talking about strength training in the postpartum period, I'm assuming that you've gotten some strength training education already and some talk about what the rest between sets should be. So generally, American College of Sports Medicine is talking about a 2 to 3 minute rest between sets of exercise. So someone might do 10 reps and then have that 2 to 3 minute rest. There was one study by Rita Daring that showed that regardless of vaginal birth or cesarean birth, nulliparous compared to nulliparous control, so people who have not had babies, that the abdominal or trunk flexor muscles had increased fatigability, so they tired more quickly at 2 and 6 months postpartum compared to nulliparous controls. And in the cesarean, people who had cesarean group, they had more fatigability at 2 months postpartum compared to people who had a vaginal delivery. But at 6 months, there wasn't any difference between vaginal and cesarean. So a big take home here, if you are working with a person who wants to do strength training, did in the past, and they're complaining about how hard it is to advance, we know that the likely solution is giving them more rest. So now we're going to talk briefly about return to running because it's a common and easily accessible exercise. Some of the barriers for someone returning to running are their experience of symptoms of urinary incontinence or pain, some complications postpartum, maybe continued vaginal bleeding, and not knowing how to safely return. And there is a lot of information on the internet, and some of that is good, and some of that is not necessarily accurate. And that can contribute to confusion on a person knowing what they should do. So in 2019, there was a document that came out that basically said everyone should wait 3 months and not even think about running until 3 months postpartum. And really, there's not any evidence to say that. And subsequently, there have been articles coming out saying that, again, it should be individually based. What was their pre-pregnancy fitness? What was their pregnancy fitness? And how are they doing postpartum and that gradual return? So some of the problems with postpartum return to running are oftentimes people had decreased hamstring flexibility and decreased hip strength. And an activity that I'm gonna try and engage you with at the end of this, near the end of this session, there's gonna be some focus on hip strengthening. So some of the current recommendations are that the individual should be allowed to decide when to return. They can seek guidance from us, especially if they have urinary incontinence, pain, or pelvic organ prolapse. If they're having any problems with sleep, weight gain or weight loss, pain, fatigue, and if there is access to a pelvic PT, if they have any leakage of urine or stool or gas, like accidentally passing gas with coughing, sneezing, laughing, or their exercise, if they have a sensation of vaginal heaviness or fullness or something like something's falling out of the vagina, and any pain with bowel movements using a tampon or sexual activity. This is a quick test to do. Maybe you've been exposed to this already. It's a running readiness inventory that is for return to running after injury. Each of these 5 activities is done for 1 minute at a certain pace, and then there's a 30-second rest. So it would take about 7 minutes to complete. And I included in your handout what the different variations that you might see, like valgus or the head position or sagging or incomplete ability to do the task for the 60 seconds. And then also talking about what a passing score could be. And as we talk about the exercises coming up, just ways we can restore that. What's nice about this test, these 3, like the odd number test, are really talking about impact readiness because there's a rapidity to the movement or a speed that they have to achieve. And then the plank and wall sit exercises are tending to look more at endurance. I like to use this because it can help. Whichever tests they don't pass can help me decide what type of exercise to move forward with. And then when doing any type of fitness progression, but particularly running, we talk about increasing 10% per week, but it's 10% in distance, because if the person's speed is increasing, and you are having them increase 10% of their time, they're potentially overtraining because they are going above the 10% increase in distance. And this running progression is not any different than how you would progress an injured athlete in the return to run. Similar to the high intensity interval training that we talked about, for some people that the 10% increase is too many calculations. So they can do a run-walk ratio. They could run for 30 seconds or a minute, walk for a minute, run again, which is good for their cardiac health. It's good for their time demands. And it's a nice way to grade the return. We're going to talk a little bit now about posture in pregnancy and some of the variations in compared to a non-pregnant state. So obviously with pregnancy, the center of mass moves forward. The lumbar lordosis increases, so there can be some increased shearing on the lumbar facet joints and more load on the lumbar facet joints. However, the female lumbar spine is designed for this from an evolutionary standpoint. Their lumbar vertebrae are more wedged shape. The facet joints in the L3 to L5 range are larger and oriented more upward. And so that move toward a lumbar lordosis or anterior tilt, the body is designed to manage. We don't have to go around correcting people or you're tilting too much or change that. They're going to adjust their posture to keep their center of gravity over their feet. So a lumbar lordosis is okay. And here's just another example of the lumbar lordosis and the pregnant abdomen with that center of mass moving forward. So it is normal to have a neutral pelvis or a slight increase in the anterior tilt. And there's variability in pregnant people, just like there's variability in non-pregnant people. And many people have asymmetric posture, and that is true in pregnant people as well. So before you're talking to people about postural changes, you really want to ask about how do they feel and analyze how they move, because they are, we've already talked about like that increase in lordosis is expected and okay. The increase in, I have a posture picture coming up, an increase in kyphosis is undesirable, and an increase in the forward head is undesirable. But people's underlying body shape and size will influence that as well. Many pregnant people are going to adopt strategies, again, to stay balanced. So, and that a big change is that is reducing the fall risk. I'm going to hold that question till the end, Connie. I did see it come in though. Some of the things that you would encourage people to avoid are asymmetric postures. So we do know that asymmetric laxity of the sacroiliac joints will increase pelvic girdle pain, which is common in pregnancy. So avoiding things like leg crossing, pulling one leg up while sleeping, carrying the baby, if they have a child already, on one hip, avoiding bending and twisting combined, and avoiding prolonged standing on one leg. And the big reason for avoiding that prolonged standing on one leg is when we stand on 2 feet, we can be well balanced, not asymmetric, and the demands on standing on one leg, on the glute med, the glute max, the obturator, and all your hip rotators is great. And so we'll spend a lot of time in longer courses talking about pelvic girdle pain and lumbar pain, and hip muscle weakness can contribute to low back pain in non-pregnant people and in people while they're pregnant, and hip muscle weakness can also contribute to stress urinary incontinence and urge urinary incontinence and pelvic pain. And you'll see that in the exercises that we choose. So to achieve balance in pregnancy, a wider base of support, so people will stand with their feet a little bit wider. They'll increase that lumbar lordosis, and they may sway backward to move their weight onto their heels to kind of get the center of mass over their whole foot, because the tendency of that abdominal weight is to pull them forward. People, because when they do postural testing, because people have that wider base of support, They tend to have less lateral sway. They may have increased sway in an AP direction because of that increasing abdominal mass. People who we typically use ankle strategies for maintaining our balance with short perturbations, but they'll move to a hip strategy. If they're on unstable surfaces, like many people, their balance worsens, and balance is poor in those who have pain. And what we're concerned about here is the fall risk. So ways that we can improve people's balance is we can modify their visual input, modify their base of support and center of gravity, and teach people about their risk of falls in poorly lit conditions. So ask them to move more slowly, transition more slowly, make sure things like orthostatic hypotension. So when they go from side lying to sitting, they take a pause and some deep breaths and ankle pumps. And similarly, when going from sitting to standing. So, and this is because 1/4 of all pregnant people will experience a fall, but people who exercise regularly have fewer falls. And this, I am not going to analyze all this data. Maybe Connie and I can get you a bigger handout, but when we talk about the ergonomics, this was the most succinct piece of information I could find. And basically what it's giving you is when people are, I'm going to go to this middle diagram, and these are people who do repetitive lifting, but for less than an hour at a time, that they can, like they're advising that they don't lift anything from the floor, that they can lift it from a height of about 17 inches, and it can be 15 inches away from them, and they can lift 27 pounds. And if it's 20 inches away, they should only be lifting 20 pounds. So it is super analytical. It's from basically OSHA in the US. So those are just some key data that you could have as you're thinking about it and compare it to what you already do with your non-pregnant population. Okay, I'm going to pause and answer some of the questions and then go into an activity where I'm going to ask you to answer some of my questions. So the timed up and go is the common test that's used as a fall screening tool. And there is a second one, but it's elusive to me right now, but I can get that information from Connie. You know, people who are pregnant with twins are going to gain more weight. They're likely to have more discomfort because of that increased weight gain and more demands managing that center of mass. They're, depending if they're pregnant with monozygotic or dizygotic twin and how many placentas they have, their risk of things like placenta previa or that vas previa, because the uterus is the same size at the start, but is now gestating 2 fetuses. So you would use your same contraindications, absolute and relative, but they're going to meet them sooner. Does that help? There's just more to monitor. But people who are pregnant with twins can exercise. And most of the studies are done on singleton pregnancies. Oh, 5 times sit to stand is just another fitness exercise that can also help with balance screening. Okay, Connie, I'm going to go into the next part, which I'm trying to, I hope this is going to work. Oh, what just happened? My My screen sharing just went away. Okay. Okay.
Okay.
Okay. So I'm going to move into progressing exercises to help people with any of the conditions that we identified above. And when thinking about progressing exercises, and maybe you've seen this already, easy exercises are going to be simple, neutral spine. They're not going to be on a therapy ball or a balance board. We're going to allow people to have a wide base, eyes open, low center of gravity. They're not going to be holding any weight. And if they were holding a weight, we're going to have it be close to them versus a long distance from the fulcrum, a high center, closing their eyes, narrow base, unstable base, a flexed, twisted, or extended spine, or an exercise that has lots of parts. So I've got some pictures coming up where there are two images of people exercising on the screen, and I've circled them in either blue or yellow, and I'm gonna ask people like which one they think is the easier one, and then the next question will be like, why did you choose that answer? And I may bump in like if and explain why that is. Okay. So we have these two people doing a plank. This person is on their forearms and their toes, and this person is on their hands and their toes doing a plank. Which one of these exercises is like physically easier on the core? The yellow or the blue? People can type in the chat or just speak.
Yeah, you could come off mute too.
And I could take the first one. And from a kind of core and hip perspective, this is the easier exercise because gravity, like the work on the core, the more horizontal you are, the more your abdominal muscles have to control that, like the descent of the spine, control gravity. But for those people who said blue was easier, blue is probably easier if you're thinking about the shoulder girdle. Like this is more complex. There are more joints. The contact with the surface is far away from the scapula stabilizers. But you're targeting your hips and the abdominal muscles, rectus abdominis, transverse abdominis, this is going to be a harder exercise. Okay, so now we're looking at a plank again, and these people look the same, right? But there's one difference, and again, which one is easier on the lateral hip muscles, yellow or blue? Hopefully the screen image is big enough for you. So this is a tricky thing that people do when they're doing planks as exercise. And it might be hard to see, but this person has their feet close together and this person has their feet wide apart. And that means they have a wider base of support. So it's less work for the transverse abdominis and less work for the hip abductors to keep her stable. So yellow was easier again when we're thinking about the lumbopelvic region. And it doesn't mean you can never have people with their feet wide, but if you're attempting to challenge their hip stabilizers and their core stabilizers, you want their feet closer together. So that would be that kind of going into a more narrow base is the harder one. And so now it's a really popular exercise. It's called bird dog. And we have two people. I know they're much older than what we would think of in a pregnant state, but they were two examples. So, which of these bird dogs is easier? The one in the blue square or the one in the yellow square? Yeah, blue, because she has a point of contact with the floor. So her base of support is still a triangle. So it's going to be easier for her to keep her pelvis stable. It could be an appropriate demand on her muscles. Sometimes you can have people keep their hand down and raise their leg up, but you give them that triangular base of support where this woman is working harder because she just has a diagonal line for support. It might be part of the reason that she's not raising her arm as high because she's challenged by such a narrow base of support. So the blue one was the easier one. And then here, apologies that you can't see their feet, but they are on their feet and their hand. And this person is on their forearm and their feet. And remember, our focus often in pregnancy and postpartum and pelvic health is on the lumbopelvic area. So which of these exercises is there a greater demand on the lateral muscles of the person's body when they're in a forearm plank or a hand plank? I just think I asked the question differently, like might have to type more. Yeah. So this one, and again, there's lots going on here. So I don't think that there's not always like a wrong answer. This one, harder on the scapula stabilizers, might be harder because their arm is pointing straight up. So they have less proprioceptive input than this person does with their hand on their hip. But when talking, if we just were purely making this about the force of gravity on the lateral hip and lateral trunk, this exercise has more demand on the lateral hip and trunk. This certainly is harder for other reasons. And here we have two yoga exercises. So I'm going to ask the question, which one is currently easier? Yeah, blue. She has the ability to have a wide base of support. She has more points of contact. She has a stable floor under her. Her arms are even more toward wide. So just like if she were walking on a tightrope, having that balance. And then this person, she probably has a pretty fixed visual input where this person is seeing waves. They have a narrow base, an unstable surface. Their center of gravity is high and toward the middle. And then here, so this is getting more complicated, right? So you're having to think about more things than just space of support and gravity. Which exercise is easier? Yellow or blue? Yeah. The yellow, like again, it could be a toss up. Like this person does have a smaller base of support down here at their foot. They only have one foot in contact, but they have wider support at the arms, but they are on a completely stable surface. They're not doing anything else with their arms compared to this person who has a wide base of support at her legs, so she might not be getting as much benefit toward her hip and lateral trunk, but there's just a lot more going on. So this is definitely the easier exercise of these two, but it's not just one step to get you to the next one, like one small adjustment like we saw with that bird dog exercise. Okay, that was my last slide that I was going to talk about. I did on your handout, I'm just a big proponent of exercise. I did on your handout include like steps to an examination, like the things that you would do. But that was intentionally provided as a supplement because I knew I couldn't get through all of it in an hour. Okay, I think I answered the questions.
Is there any other questions for Sandy? I cannot believe, Sandy, you did it. It's 6:01. That is amazing.
I really hope.
Here's a question for you.
Yep, the timed up and go and 5 times sit to stand can be applied in all scenarios. I mean, like what if it's a pregnant person who like sprained their ankle or had a torn ACL or had a labral tear? You're going to treat it similarly to a non-pregnant person. So I don't know if we can ever say like 100% of the time this will just be what you would do. A lot of times what I look at is I'll have people do a toe stand or I'll have people just do a single leg stance. And I'll have my hands ready. And if I see a lot of sway, I know that I need to do something about their balance strategies or their strength in that area. Did that help? But yeah, but the stage of the pregnancy, I will have to, I do have that information. I don't have it off the top of my head, how the scores change, but I can get that to you. Through Connie, right?
Yeah, because I sent it through the international office.
Okay.
Oh, thanks with love. You're supposed to do a little thing about having them ask you to come to Thailand.
I'm supposed to do it like that.
So
I love talking about exercise and ways that physical therapists and occupational therapists can progress exercise and make it fit where the person is and just take it that one step further, or if they're having problems, take it that one step back. I remember in my favorite activity in PT school in 1985 was an activity just like that. I love doing things like that. I think exercise is such a great intervention for so many things, and I don't want people to be afraid of it. I want them to find their level. Like I'm a really big proponent of that. And if you liked that activity, like if you like being like guided in learning, that is something that I absolutely love to do. Like I love to talk, but I also like to have conversations and see change and see learning and have people like feel it within themselves, because I think that's where the true learning takes place. And I'm excited. I don't know if I'm going to meet if any of the 6 people who are coming next week are in this group right now, but I'll be excited to meet you in person, and I'm excited for that presentation as well. So.
thank you so much, Sandy. As always, I learned so much from you.
Okay.
I was only right 1 out of 5 times.
I mean, yes, sorry about that. I mean, it is to get people to think.
Yeah, it's great. It was great. Thank you. I'll send out you the last PDF you sent me.
Okay.
And then Mr. Tun will get the evaluations for you.
Okay.
And today you had over 73 people.
Oh,
attend.
wow.
Yeah. So, and lots of hearts coming up,
Okay.
clapping. So
Okay. All right.
thank you so much.
Okay. Thank you.
Sarika, have a good day, everyone in Thailand.
Okay. Connie, do I have to transfer the host to you?
No, I'm just gonna stay on to meet with them. So you're
Okay.
good.
And so
You
when
can
I
just,
leave, it's not going to end the meeting.
nope, but